So thank you very much. Great meeting. Good to see everyone. I can't believe it's been 2 years, 3 years now since the whole COVID stuff. Anyways, so this is really a study that has been really at the core of Anchor with John's all work. So we have a good multi-center collaboration over the years, and that permitted this RCT, and this is a subgroup analysis of the RCT, and obviously our fellow Jeroen Verheugen did a lot of work on that. Disclosure, this is supported by a grant of the Canadian Institute of Health Research that supported the research for this. What is dysplasia or instability? To me, it's really where the femoral head has an unpredictable path of motion leading to abnormal loading of the cartilage as well as overactivation of the musculature and ultimate fatigue. And I think this is where the PAO, as nicely shown by Jeff and their group, and as well as here in Bern, is this gold standard in terms of treatment. However, we do know that a good percentage or a high percentage of these patients will have intra-articular pathology that could be left untreated at the time of the periacetabular osteotomy, and some have advocated the combined use of the scope and the PAO in the treatment of these individuals. And the question is, who's the right candidate to do this? So should we do it all, or should we select or not? Hard to know. And in terms of value in healthcare, which is also relevant, we know that plain radiographs provide value in terms of diagnosis. Well, what is the value of the hip, MRI of the hip in influencing treatment in the symptomatic dysplastic hip, which is that kind of that cost over the health outcome of that delivery of care. So the primary aim of this subgroup analysis was to evaluate the utility of preoperative MRI, of standard MRI in patients undergoing PAO for dysplasia, and does these findings influence treatment and the outcome. So as alluded to, this is a part of a larger randomized trial comparing scope at the time of PAO. We've recruited over 200 patients now, multi-center. The trial is closed, so we're doing our 1 or 2 year follow-up. But this is a subgroup analysis of the arm that underwent the arthroscopy at the time of the PAO. So it's a group of 72 patients, of which 54 of the 72 had a labral tear read on MRI. And this, I'll show some of the limitations of that. So here's the cohort of those 72, mean age 26. No significant difference in the patient profile between MRI tear or no tear on MRI in terms of radiographic measurements, as well as the only aspect was the alpha angle, which is a bit higher in the no labral tear, but that is inconsequential, and presence of cavum deformity was comparable on both sides. In terms of other MRI findings, in terms of cysts, femoral head cysts, and cartilage damage at the time of surgery, you can see that the only real difference was the aspect of treatment between the two groups, where the patients that had a labral tear on MRI were more likely to have treatment at the time of the scope than not, which is, I think, makes some sense. But there were no other difference in surgical variables. So results. So overall, in the 72 patients, 64% had labral treatment, which was a variety, some terminal shrinkage or what I call Botox of the hip, or some labral debridement or labral repair in about 46%. What's interesting here is 6 of the 18 that did not have a labral tear on MRI ended up having labral treatment at the time of the scope, and 74% with labral tear on MRI had also only 74% who had labral tear MRI ended up having labral treatment at the time of the scope. So this gives us a sensitivity of 87% and a specificity of 46% of the MRI diagnosing labral pathology. How about the impact on PROMs? So if you had a labral tear on MRI, there was no significant difference in pre-op IHOT. These were the 2-score, IHOT 33 and WHO score. We don't have the full 2-year follow-up, but the vast majority are at 1 year, and there was no kind of impact on terms of at the latest follow-up if you had a labral tear on MRI, either on IHOT 33 or WHO's. Treatment. Again, no difference in terms of at the 1 year follow-up. We're still, as I say, waiting for the 2 year follow-up. So no significant difference in terms if you had labral treatment or no treatment at the time of arthroscopy in your PROMs, both on the IHOT 33 and the WHO score. There was no difference in terms of adverse events in the two groups in terms of tear or no tear. So obviously this has some limitations, which Hollis knows well. These were clinical MRIs at the various centers. So we just took the report that was done by the radiologist, either on a 3T or a 1.5T with arthrography. And as I mentioned, so there's probably some variability there in terms of reporting and accuracy, and we're kind of trying to look at that in a bit more detail, looking at one standard MSK radiology. We're working with Coven Radcraw and the Anchor group to see if we can have better definitions of our tears and see if we can improve the reliability. So that's ongoing work. Most of our patients only have 1 year follow-up. And again, this does not really answer the question, is scope of value at the time of PAO, but this is part of the larger RCT, which we're completing the follow-up in the next year or so. Obviously, this does question the value of MRI in the management of symptomatic dysplasia. So again, symptomatic dysplasias, you have a diagnosis of dysplasia on plain x-rays. What's the value of MRI? Doesn't seem to help much in terms of treatment. And these are similar findings that Steve Olson reported out in terms of advanced imaging for diagnostic value in FAI. And there is a cost. Our cost of MRI in Canada is, I don't know how it's compared to the US, but it's about $1,000. So for us, it's still relatively much more expensive than plain x-rays. So to conclude, to us in this study, a standard MRI in clinical practice didn't seem to add value in the management of labral pathology in symptomatic hip dysplasia. Doesn't really answer the question in other just non-dysplastic hip that have a labral tear. I'm sure there's value there. The labral treatment at the time of the PO did not improve the clinical outcome. And obviously, we have to await the larger trial, the usefulness of T1 row, and we're completing a cost-UT analysis with WashU in terms of that aspect of the use of the arthroscopy. Merci. Thank you.